So I'd like to welcome everybody to Pediatric Grand Rounds. A little bit of housekeeping first. Remember to please log in to the tracking system we use for CME. Even if you're not claiming credit on CME, that helps us continue this lecture series and hopefully at some point in the future justify purchasing meals as well. Also, I'd like to declare that Dr. Thomas, who is our speaker today, has no conflicts of interest. So today it's my pleasure to introduce Dr. Cynthia Thomas. Dr. Thomas is originally from Princeton, West Virginia, and completed her medical school training at West Virginia School of Osteopathic Medicine. She then went on to Emory, where she earned her completed her residency in general preventative medicine and public health and earned her MPH degree as well. She went on to join us in Northeast Tennessee at the Tennessee Department of Health. She's based out of the Northeast Tennessee Regional Health Office. She does primary care there. She's also an assistant health officer, so she's responsible for developing and implementing prevention initiatives for the entire region. She focuses on maternal and child health, and she's also the liaison for the COVID-19 response for the school system in Northeast Tennessee. She serves on child fatality review boards for Northeast Tennessee, as well as on the ETSU Maternal and Child Research Collaborative Advisory Committee, and several other committees, including the Meet the Mountains Festival Committee for last year, which is an awesome festival, which I think brings us to one of her personal passions. She has run an ultra trail marathon, or excuse me, Dr. Thomas, trail ultra marathon in 2019, which sounds incredibly difficult, but today she's going to talk to us about the Northeast Tennessee COVID situation and kind of some of the responses from the public health perspective. And I'm sure it's definitely a fascinating topic and definitely a timely one. So I will turn it over to her. Dr. Thomas.
Thank you so much, Dr. Dodd, and thank you to everyone for the invitation to join you today. I'm excited to be with you and to have the opportunity to share some of the updates in regards to the COVID-19 public health response in Northeast Tennessee, and specifically how that applies to schools and school-age children, which I hope is of interest to you. Can you all, just let me make sure, can everybody hear me okay? Thumbs up, awesome, okay. So I'm going to start off by sharing my screen and sharing my PowerPoint presentation with the caveat that we're going to switch gears and go to live data for a little bit of the presentation. As you can imagine, COVID-19 and the public health response to COVID-19 is quite a fluid situation. The data changes literally minute to minute, and the guidance evolves almost as rapidly. And so I put together my slides with the knowledge that I was going to hope to share live data with you, because even just having put those slides together a couple of days ago, some of that data is already pretty old and obsolete. So we will start off with the slideshow. We'll shift gears and go to some live data, which will also give you the opportunity to see where you can find that on your own if you would like to peruse that data some more. And then hopefully we'll have some time for questions. So I'm going to start with kind of a general overview, and I'm just going to ask for your patience. The first couple of slides are just to make sure we're all starting from the same page, and will seem fairly elementary to most of you, I'm sure, but just to get some kind of vocabulary out of the way and make sure we're all referring to the same things in the same way. So bear with me and we'll get to the meat of the presentation within a couple of slides. So let me share my presentation with you. Okay, can somebody just give me a thumbs up that you can see that PowerPoint presentation? Awesome, I see Dr. Dodd giving me a thumbs up there. So I'm going to start off with, well, of course, my disclosure, nothing to disclose. And then we're going to just cover a little bit of vocabulary. I know you guys know this, bear with me. SARS-CoV-2 is the actual coronavirus. That's the virus that causes the disease that we call COVID-19. And so we always just like to make that clear especially for our community partners, so that, because both of those are kind of thrown around, just to make sure that we all are aware that SARS-CoV-2 is the actual virus. COVID-19 is the disease caused by the virus. As you are all aware, the primary means of transmission of COVID-19 is through the sharing of respiratory droplets. Respiratory droplets are produced when we cough, sneeze, talk, sing, yell, any of those things. And those droplets can kind of travel through the air, and depending on their size, they fall to the ground within a couple of feet, or they can continue to move through the air and can land on the mouths, noses, eyes, or other parts of another person, and or potentially be inhaled, and that's how the virus is thought to spread primarily. When we talk about community spread or community transmission, that just means that the virus has been spreading easily and sustainably in a given community. And the marker of that is really that folks are becoming infected and don't know where they were exposed. So when we have a number of people who are becoming infected but can't track back their exposure to a specific time or place, then we refer to that as community spread or community transmission. Of course, as you all know, SARS-CoV-2 is a particularly sneaky little virus in that folks become infectious prior to developing symptoms, and may be infectious even if they never develop symptoms. So with folks spreading virus before they're aware that they're ill or never having known that they were ill, viral transmission can occur very effectively before there's any interruption in that disease. So what are the clinical manifestations of COVID-19? Well, they are many, and most of you are familiar, I'm sure, with these. But the symptoms there: fever, chills, cough, shortness of breath or difficult breathing, fatigue, muscle body aches, headache, new loss of taste or smell, sore throat, congestion, runny nose, nausea, vomiting, diarrhea. And as all of you in clinical medicine will understand, with the exception of new loss of taste or smell, a lot of those symptoms are characteristic of a very many ailments that we see pretty typically in adults as well as in children, which makes it a little bit difficult to rule out COVID-19 when folks have basically any symptoms. So we'll talk about how that complicates matters and how the public health response has to take that into account as we go forward. So what's it look like in kids? Well, many of the same symptoms, obviously, but compared with adults, at least the evidence that we have so far suggests that children are more commonly asymptomatic or very mildly symptomatic with COVID-19. Obviously, there are exceptions to that, and we'll talk about that a little bit more. But so far, it looks like children are typically more mildly symptomatic than adults as a group. Of course, as I know all of you in this room are aware, children with certain conditions may be at increased risk for severe illness. And there's also a rare but serious complication associated with COVID-19 in children called multisystem inflammatory syndrome in children. And my job today is not really to go into the details of the clinical manifestations of COVID-19 in children, but rather to focus on the public health response. So we're only going to touch on that briefly. And so epidemiology. So here's where we get into what does it look like? What are we seeing in terms of globally, nationally, across the state, regionally, and locally? So I will just stick with the numbers as of September 21st when I submitted these slides in terms of the global burden of disease and the national burden of disease. And I'm sure you guys have seen these numbers. They're extremely large numbers in terms of the cases identified globally, deaths associated with COVID-19 globally. And in the US, we're approaching 7 million cases in the US and 200,000 deaths. This is from the COVID-19 in Tennessee at a glance critical indicator report, and I'll show you where you can find that. And this was as of September 18th, so we'll go into the live data in a moment. But as of September 18th, there had been a little over 180,000 cases identified in Tennessee. As of September 18th, there had been almost 2,500 cases, new cases that day. And there have been a little over 2,000 deaths associated with COVID-19 in Tennessee. And I'm just going to give you some numbers here as of September 21st for the counties that make up the Northeast region. And this is the health department region. So for those of you who are not familiar with how the health department is kind of set up, We have metro regions, and then we have rural regions, which are under the direction of the central office in Nashville. And our Northeast region is composed of these 7 counties listed on this slide. So in the counties of the Northeast region, these are the cumulative number of cases as of September 21st. And then in the parentheses is the death, cumulative death rate, or not rate, excuse me, death number of deaths in each of those counties. And this is where I'm going to switch gears and show you some of the live data. So what I'm going to have to do is stop sharing and then reshare. So bear with me for a moment. And I'll take us into some live data. Okay, can I get a thumbs up? Do we see the Tennessee Department of Health? Awesome, okay. So this is, actually let me go back so you can see from the beginning. This is the Tennessee Department of Health Coronavirus Disease Information page. And so if you Google Tennessee COVID-19, this is most likely going to be your first hit. And so if you go to the site, and I'll also send you guys these links and some follow-up notes if that's helpful. So if you go to this site, that's where you're going to get the cases, deaths, hospitalizations, and tests for the previous day. This is updated at 2 p.m. Central Time, 3 p.m. Eastern Time every day. This is where the critical indicator report that I was showing you a screenshot of is located. This is also where you can go into complete data report and surveillance information regarding COVID-19. So this is where you'll find epicurves and maps and county data snapshots, which I would encourage you to explore if you've not had the opportunity, because you know everybody loves that stuff, right? So if you go into the epicurve, you can see the epicurve for the state as a whole. So as you will see, you know, starting back in March, we had a fairly low level of cases for a period of time. Starting in late June to early July, we had a very rapid increase with a steep incline in numbers of cases. We started to level out around early to mid-August and even show a slight decline. Now we're seeing kind of a slight incline. So we're waiting to see how travel over the Labor Day weekend and increased numbers of children in-person instruction will impact our community transmission and therefore our case rates as we move forward. So when you're looking at the epicurves, you can go in and select a region. So if we want to go look at the Northeast curve, we can look at that. So those are those 7 counties that I just showed you. And you can see that basically the epicurve kind of reflects that of the state as a whole. It's not a whole lot different in our region. You'll see day-to-day ups and downs in cases, and we always urge caution in looking at those kind of day-to-day changes in numbers, because some of that just reflects when lab reporting happens and so forth, and is not really a true reflection of how many cases were identified on a given single day. I will also show you that on the epicurves, you can look at the epicurve by county. So if you go to the second tab there and go new cases by county, and use the drop-down list, you can find, we'll just pick on Carter County because it's easy to get to right here. And so you'll see that this is the epicurve for Carter County, and you can look at the epicurve that is specific to each county. And so you'll see that, you know, what happened here. Did Carter County have 87 new cases on this day? And actually, no, this was a result of a data quality change, which reassigned cases to the correct county after they were erroneously assigned based on their zip code. So sometimes the zip code has put them in the wrong county, and so all of that was corrected on the same day, which resulted in some weird looking data. So always, if you're happening to look at that and you have some questions, please get in touch with us so that we can clarify any of those points and help with interpretation of the data. Now, I'm not going to belabor the point here of what's available on this site, but I am going to show you a couple of other things very quickly. So recently added was a county data snapshot for each county. It's a wonderful resource. And so if you go in and select your county, so let's see if we can get to Washington easily. So here's the county data snapshot for Washington County. So it will give you the cumulative number of cases, hospitalized patients, deaths, inactive and recovered cases, and then it's going to give you not only the cumulative case count, but it's going to give you a daily case rate for the past 7 days, as well as for the past 14 days, as well as that epi curve that we looked at on the other page with the isolated epi curve. And then it's also going to show you testing rates and percent positivity. So this is important because we need to know how many folks we're testing and how that's impacting what we're seeing in terms of cases. But we also want to know what's the percent positivity. That's an indicator for us of whether or not we're doing sufficient testing to capture the true level of community transmission that's going on. And so you will also see that there's a reference to the zone of the White House Task Force map. And so I'm going to go ahead and take us to the task force map. And the White House Task Force map takes into consideration a couple of different data points. Primarily case rate and lab test positivity, and then assigns a specific zone to each county. In relation to schools, which is the area that I'm working in primarily right now, the zone, the White House Task Force zone, is we only really recommend that it be used to guide this part of the case response rubric that schools use for decision making when a case is identified in a school. And we'll get to that in just a little bit. I'll show you exactly what I mean. But they've just added this orange zone. Prior to, I think, yesterday, there were only red and yellow zones. Now there's an in-between orange zone. Right now, our counties of Northeast Tennessee, our only county in the red zone is Johnson County based on this criteria. We have 2 counties, Unicoi and Hancock, that don't fall into these categories at all based on their case rates and their positivity rates, and then the remainder of our counties are all in the yellow zone. Okay, now let me take us back to the county data snapshot. And I'm actually going to show you how to get to some other really useful information that would be of value to you guys working in pediatrics, especially for school-aged children. So these are going to be found on this tile, educational resources. So one of them is the table of cases among school-aged children, which is updated daily. And so this table kind of shows a pie graph of the proportion of cases by age group in that school-aged age group. So, and it's not broken down, if you'll note, there's not an equivalent number of years in each of these groups. It's really broken down into elementary age, middle school age, and high school age. So high schoolers are making up the vast majority of cases among school-aged children, but about a fourth are among elementary age children, and close to a fifth are among middle school age children. Also on this table is available the actual total number of cases in school age children for each county, as well as the number of cases over the last 14 days. So that's been beneficial for our school decision makers and other folks in the community who are caring for school-aged children in determining, what exactly is happening day to day in terms of the number of cases identified within the previous day, since this is updated daily. There are also downloadable data sets. You may not want to get into all that, but there's a lot of downloadable data sets that are available based on age. And so if ever there's information that you want and you can't specifically find it, please just reach out to us, and we're happy to work with the data we have to provide the information that you need. This is another resource. It's also located under that Educational Resources tab. This is all children aged 0 to 18. This is updated weekly. The most recent revision, update was on 9/21. And this shows, of course, the same sort of pie graph, but includes children less than 1, as well as children aged 1 to 4 years right here. So you'll see that that 14 to 18-year-old age group still makes up the largest percentage of cases. However, you can see the breakdown for those 1 to 4-year-olds and those less than 1 as well. I always find this the most useful piece of this particular data set or reporting is the number or the percentage of the total cases that are represented by children and how that's changing week to week with new cases. So the past 2 weeks, it's remained the same. at about 15.5% of all new cases during that week were identified among children. The previous week before this 8/30, so the week of 8/23, it was 14.8%. So we're watching that week to week to see if the percentage of total new cases that are identified among children is going up as a percentage of the whole. And you can also see a breakdown of gender, race, and ethnicity for cases in each age group here, so that you can compare those in children to other age groups. There's also a bunch of other information here. I'm not going to go through all of that, but there's certainly other things that you can look at there at your leisure. In your theoretical spare time, you can go in and review all those. And so there's a lot of other information here. We're going to come back to some of it, but that's primarily the data I wanted to look at on the website and give you just kind of a picture of what the epidemiology looks like in terms of Tennessee as a whole, our region, and then school-age children and all children. I'm going to stop sharing this and go back to my PowerPoint. Uh-oh, I think it started over. Let's see. Let me get to the correct slide here. Oh, you know what? Actually, I do want to show you something else. Let me stop sharing that and share one other thing. Apologies. I wanted to show you some data that we put together locally here for our region. So are you guys able to see those charts that start with Northeast region? Okay. So our regional epidemiologist on our school team here puts these summary charts and graphs together for us each week. These were compiled yesterday. So this is showing our case rate, our daily case rate for the last 7 days in each of our counties in Northeast region. Kind of gives you just a snapshot of what the case rate looks like for the past 7 days as compared to the week prior. So some of our counties have seen an increase in case rate, while others have seen a slight decrease. So we've got 2 counties with a decreased case rate as compared to the previous week. The remainder of our counties have increased percent positivity. So this gives us an idea by county about whether or not we feel that we're doing sufficient testing to really capture the level of transmission that's going on in each of those counties. And there's a kind of a varying threshold for that. We'd say generally speaking, we want to see the percent positivity lower than 10%, certainly, to give us that reassurance that we're doing enough testing to identify all of those cases in the community. As you can see, many of our counties are currently at or above that 10% threshold. We have seen a decrease in demand for testing, and this is actually the test rate. But just to give you kind of an idea, at our peak of testing, which was back in July, as compared to the peak, we're doing about 1/3 of that amount of testing now. And that's just based on demand. Testing is available at every local health department free of charge to that person being tested. Anyone who is seeking testing may be tested, but we've had a decrease in demand, which has resulted in about 1/3 of the folks being tested, as was the case at our peak. Now, we have seen a slight increase this week, which we believe may be due to new CDC guidance about testing of asymptomatic close contacts. So we'll see, we'll continue to follow that and see how that changes over time. So some of the other things that Edward puts together for us in terms of the Northeast region is kind of looking at new cases day over day, and age distribution of cases in the Northeast region. So the majority of our cases have been identified among 21 to 30-year-olds, which is the same for the state. And so although that's not true of every one of our counties, in several of our counties, the highest number of cases has been identified in the 11 to 20-year-olds. However, as a region, 21 to 30-year-olds represent the largest number or percentage of cases. New cases in 5 to 18-year-olds day to day, which we're following over time. Percent of new cases each day that are in the 5 to 18-year-old age group. And then just briefly for each county. So this was something that we've just added, which we think is going to be beneficial, is looking not only at the age distribution of COVID-19 cases, but how many people in each of those age groups are actually being tested and what's the positivity rate among those age groups. So that gives us an idea of, are we seeing not very many cases in this age group because there aren't very many, or are we not seeing very many cases in this age group because we're not testing them? So for each county, that looks a little bit different, which is why we've provided that information by county. If ever you have questions about that or you'd like to look at this information further, please just get in touch with me. Happy to provide that for you and help with any interpretation that's needed. So I just wanted to show that to you guys really quickly to give you an idea of what things are looking like around the region. And then I'm going to shift gears back to the presentation, and I'm going to actually, oh, it went back. Sorry. I'm going to just go through these very quickly because we've already touched on all this with new data. So I'm going to shift gears to kind of considerations for schools. That's currently where I live right now as the school lead for the Northeast region at the health department in our public health response to COVID-19 in schools. And so I'm just going to kind of go through this briefly because I think it may be of interest to you guys. So in considerations for schools, you know, especially in June and July, the major questions that everyone was asking is it safe to resume in-person instruction? What are the considerations there? What are the indicators for when and how we need to do this? And so a lot of the discussion had to do with balancing the harms of school closure with the risks associated with reopening. And so what are the harms of school closure? Well, we know that remote learning can't fully replicate in-person learning experiences, especially for our youngest learners and for those with special needs. We know that vulnerable populations may have limited access to community-based services, which are usually delivered through schools and may not be accessible to them when schools are not in session. We know that domestic abuse or neglect may go undetected when schools are not in session and there's no means of recognition of that abuse or neglect that's going on in the home. We know that distance learning and exclusion from school may produce or exacerbate social isolation, especially among children who already are at risk. And we know that school closure presents challenges in regards to childcare for working parents. So those are just some of the harms of school closure. So what are the risks of school opening during the in the context of a global pandemic? Illness among students, clearly, illness in school employees, illness in the household contacts to students and school employees. Some of the unknowns at the time that we were, kind of entering in the discussions were what is going to be the potential for increasing community transmission that's associated with schools. And could that translate to increases in hospitalizations and deaths and an increased risk of exceeding capacity to provide appropriate care by healthcare facilities? And so at the time when all of this discussion started, there was kind of a paucity of data around what it was actually going to look like in the US. Because since we had had any significant numbers of cases in the US, we had essentially had kind of a lockdown and children had not been in congregate settings, had not been in school or childcare. So we really didn't know what it was going to look like in the US, and we really had to base decision making on global experiences to date and the evidence that we had to work with. And so when we started all of these discussions, the evidence that we had suggested that children were at lower risk of serious long-term consequences or death as a result of contracting COVID-19. But there was insufficient evidence to really know how easily children and youth were going to contract the virus and how contagious they were once they did. So, what was it going to look like in terms of transmission within schools and how that translated to transmission in the community. And so, there was just very mixed kind of results of school reopening globally. Everything from not really seeing increased cases among school students and employees and not really seeing an increase in community transmission, all the way to schools having to be reclosed broadly and lockdown procedures put back into place in the community. So there was very mixed results, and of course across countries, when you're looking at globally, There were differing mitigation strategies in place. There were different mechanisms for reopening schools, hybrid models, and so forth. And so it's difficult to make any really evidence-based conclusions about what we might expect in terms of in the US. And then we started to have lots of new information becoming available in the US, which can further inform really our decision making. And so some of these had to do with transmission. So we learned more about the transmissibility of SARS-CoV-2 among children of various ages. We learned more about how young children may actually transmit the virus to their household contacts. We've understood more about what is the risk of severe COVID-19 illness in children and what does it look like for them in those hospitalized children. We've learned more about mortality in children with COVID-19. So we continue to gather evidence to help us understand, as I said, this is such a fluid situation with such evolving data and information, and it's going to further support guidance as we go forward, but that does contribute to ever evolving guidance and changing guidance about how we do things. And nowhere do I think that's been more evident than in schools. So just briefly, so the TDH recommendations for the management of COVID-19 in schools kind of work on the premise that while no single action will eliminate the risk of transmission of the virus within a school or school district, implementation of coordinated interventions may significantly reduce the risk. And so the primary mitigation strategies that have been focused on in terms of mitigating the risk of COVID-19 in schools include exclusion from school for people who are sick, physical distancing, not allowing your respiratory droplets to land on anyone else, the use of face coverings to keep your respiratory droplets to yourself, hand hygiene, which is of course always a good idea, and the use of cohorts, which usually is really just minimizing crossover between multiple groups of children and staff members, so that if there is asymptomatic or pre-symptomatic infection going on, that the viral transmission is limited to a smaller number of individuals. And so that brings me to, we're going to revisit schools, but it's going to take me to the public health response to COVID-19. I think there's probably differing levels of familiarity with what the public health response to communicable disease looks like. So I just wanted to kind of take you through that. So obviously the public health response to any communicable disease really has to do with identifying folks who are sick, identifying people who've been exposed but aren't yet sick for a variety of reasons. So one of those is to be sure to identify folks for the purpose of notification, offering testing and or treatment, offering counseling and guidance, and interrupting disease transmission. So as I'm sure you're all aware, COVID-19 cases and COVID-19 related deaths are immediately reportable conditions. Every case, and I forgot to put the case definition in here. We may go back and revisit that, but just briefly, so when you hear us talk about a COVID-19 case, a confirmed case is any individual with a positive PCR test. So if you test positive for, if you have a positive PCR test, then you are a confirmed case. You are, you have COVID-19, you have SARS-CoV-2, regardless of symptoms or known exposure. A probable case is someone who has had a known exposure to a confirmed case of COVID-19, so that's an epi link, as well as meets certain clinical criteria. So someone who is symptomatic with symptoms consistent with COVID-19 with a known exposure is considered a probable case regardless of a test result or lack of testing. And we can come back to that if there's any questions, and I will follow up and put it somewhere. I will send it to you guys. It is under the public health tile on that COVID-19 page. So case, that's what we're talking about when we're talking about a case. When we talk about, you know what, let's see. I thought I had a slide in here about contacts. So I think I do, but it may be after this. Let's just touch on it here. So a case is someone who has either had a PCR test result that is positive or has been identified as a probable case based on an EpiLink and clinical criteria. A contact is someone who has been in close contact with that confirmed case, and close contact is generally defined as within 6 feet for 15 minutes or more, having had physical contact, so hugging, kissing, etc., counts as close contact. Sharing utensils. We also often consider sharing a phone for more than a brief period of time, since it's been in close contact to both people's faces. And there are other more brief exposures, but with higher likelihood of viral transmission that would also be considered close contact. So when we're talking about schools, an example would be athletic teams where perhaps there's been a huddle in a football situation and the case has been the quarterback yelling out plays in the huddle or whatever. And so each interaction and each scenario really has to be looked at specifically by public health to determine those close contacts. But those are just some general guidelines for close contact. So isolation is what separates people who have the virus from people who do not. So when we're talking about the case is isolated. So isolation refers to people who have the virus. Quarantine is what we recommend for contact. So quarantine just separates people who have been identified as exposed and may be incubating the virus, to separate them from other people who have not been exposed to prevent transmission. So contacts are quarantined, cases are isolated. And so here's isolation and quarantine guidance from the Tennessee Department of Health based on CDC guidance. So if someone is identified as a case, they must be isolated for a minimum of 10 days after onset. So either after symptom onset, that's the first day of isolation, or if the person is asymptomatic, it's the date of their positive test. So isolation starts either day of symptom onset or day of a test in the asymptomatic individual. Isolation continues for a minimum of 10 days and must continue until the individual is afebrile and symptoms are improving for 24 hours. And there are some caveats. So severely ill patients, the recommendation is isolation for at least 20 days for severely ill patients. Asymptomatic cases must be isolated for 10 days through 10 days after their specimen collection date, regardless of if they never develop symptoms. They still must be isolated for that minimum 10-day period. And then there's just some guidance based on kind of what prevents them from being released from isolation and what would be indicated if they had a return of symptoms. So if the case has been isolated for a minimum of 10 days, has had complete symptom resolution and afebrile for 24 hours, has been released from isolation, but then has a return of symptoms after that, after complete symptom resolution, they do not have to be re-isolated. So there is that caveat. Quarantine for household contacts. This one's a little confusing for folks sometimes. So household contacts have ongoing exposure to the case throughout the time that the case is infectious. So household contacts must quarantine throughout the isolation period of the case, plus 14 days after the isolation period. So again, the reason for that is that they are exposed to the virus throughout the infectious period of the case, and then could be incubating the virus and start to shed virus themselves anytime in the 14-day incubation period after that 10 days. So household contacts essentially are going to be quarantining for 24 days from the day of symptom onset of the case, or the date of the specimen collection for someone who is asymptomatic. There are some caveats here as well. So if the case can completely isolate away from household contacts, and that can be confirmed by our case investigators. So this means the case is never in the same room as other household members. The case cannot share any utensils, cups, dishes, phones, etc., and should have their own bathroom. There's a list of criteria. If they can meet those criteria, then the household contacts can be considered non-household contacts for quarantine, and quarantine for 14 days from the day on which the case was able to isolate away from them. We do like to confirm that with our case investigators, talking to the case to be sure that they meet those criteria before allowing household contacts to be considered non-household contacts in terms of quarantine. One thing that I need to point out, because this has happened frequently and is an unfortunate event when it does happen, is if you have a case in a household contacts are quarantining, and another household member becomes a case, then all the household contacts quarantine period resets to the symptom onset date or positive test date of the next case. So the most recent case in a household, if there are multiple cases, their symptom onset date or date of positive test sets the quarantine period for the rest of the household. Now, if the case has completed their own isolation period, has been afebrile and has had resolution of symptoms and is released from isolation, they do not have to quarantine with subsequent cases in their household, because they are believed, based on the preponderance of evidence that we have currently, to have at least short-term immunity to SARS-CoV-2. So if they've completed their own isolation period, they do not have to quarantine after completion of their isolation period. However, everybody else in that household who's still just a contact, has not become sick themselves, must quarantine based on the most recent household case. Non-household contacts is a lot more straightforward. So if you were exposed to someone, you had close contact with someone who has a confirmed case of COVID-19 outside of the household, then quarantine would be for 14 days from the date of last exposure. That's pretty straightforward. Okay. So we'd like to point out to everyone that contacts to a confirmed case are advised to remain in quarantine for that full 14 days, even if they're not sick and even if they test negative. So if you want to be tested, you can absolutely be tested. It's available to you in every local health department in Tennessee. You're welcome to be tested. However, if that test is negative, it does not change or shorten your quarantine period at all. And it doesn't even matter if you have 4 or 5 negative tests. You need to still quarantine for that 14-day period. Now, there are caveats to that. I'm not going to go down the rabbit hole of that. Currently, there are some caveats to that for for healthcare providers, which we can go into if there are questions about that. But essentially, everyone is asked to quarantine for the full 14 days, even if they are asymptomatic and even if they have a negative test. Okay, so that's the public health response in general. Public health response in schools. So I'm going to go through this because I think it's important to everyone as pediatric providers and primary care providers to be aware of the return to school criteria for staff and students in schools as it relates to COVID-19. So this is the Public Health COVID-19 Return to School Decision Support Algorithm that's been made available for schools to use in determining return to school for their staff and students. And so this kind of breaks things down. As you can see, it begins in this top box up here with symptoms of COVID-19, and it had, in an update from its initial iteration, it has now categorized those symptoms as either high risk or low risk symptoms. So new onset cough, difficulty breathing, loss of taste or smell, and fever greater than 100.4 degrees Fahrenheit are considered high risk symptoms. Chills, congestion, runny nose, nausea, vomiting, diarrhea, sore throat, headache, myalgia, and fatigue are considered low risk symptoms. And so this kind of breaks things out into if they have no known exposure to COVID-19 and have one low risk symptom, then they should be excluded from school, but may return to school after 24 hours and 24 hours of improvement in symptoms, afebrile and improvement in symptoms, excuse me. And so this allows for the opportunity to see if symptoms are going to progress or worsen in that 24 hours, or if there's going to be resolution and fairly sufficient evidence to suggest that the child may return to school. No known exposure to COVID-19, but having 2 or more low-risk symptoms or a single high-risk symptom, then the child should be excluded from school and testing and/or evaluation by a healthcare provider recommended. So this is where it gets a little hairy. So with a negative test result, a student may return to school after they are fever-free without fever-reducing medications and their symptoms are improving for 24 hours. That negative test result does need to be a PCR test. You'll see in the footnote for negative tests, number 4 down here, a negative antigen or antibody test is not approved for return to school. And they will need documentation of a negative PCR test for return to school under that criteria. They can have a medical evaluation without testing with an acceptable alternative diagnosis. So they may return to school after 24 hours of being fever-free and improving symptoms and with a medical provider's note reflecting an acceptable diagnosis. So what is an acceptable diagnosis? Well, there's a footnote down here, number 7, that gives some examples, including fever due to urinary tract infection and a variety of others. And it gives some examples of diagnoses which do not rule out COVID-19 and would not be considered acceptable alternative diagnoses for return to school without COVID-19 testing. So diagnoses of respiratory and viral conditions, allergic rhinitis, seasonal allergies, upper respiratory tract infection, pneumonia, pharyngitis without a positive strep test, or viral illness would not be considered acceptable diagnoses for a return to school without COVID-19 testing because those diagnoses cannot rule out COVID-19. Then there's another little situation here. So if there's been no medical evaluation, no testing, or the alternative diagnosis is not acceptable or not deemed to be acceptable by the algorithm, then the student must isolate for 10 days and from symptom onset and be 24 hours fever-free with symptoms improving prior to return to school. So some parents choose not to be seen by a healthcare provider nor to test. And in that circumstance, the student would be asked to be excluded from school for 10 days from symptom onset and be fever-free and symptoms improving prior to return to school. And I said student, but staff would be obviously the same, school employees. And so the last circumstance over here is a positive test. Obviously, a positive test is going to warrant a 10-day minimum isolation period and being fever-free and symptoms improving for 24 hours prior to release from isolation and return to school. Now, the other 2 circumstances up here have to do with someone who's been exposed. So if there's been a close contact, obviously those students and staff should be excluded from school due to quarantine. If they develop symptoms and they meet the case definition, they will be considered a probable case and asked to isolate and notify public health so that a case investigation can be completed, and they would not be able to return to school until completing their 10-day minimum isolation period. If they have been exposed and have no symptoms, obviously they are still going to be in quarantine, and they would be asked to quarantine for 14 days from the date of last contact if it was a school-based exposure. If it was a household contact, they would be asked to quarantine according to household contact guidance. And then we do recommend that in anyone who's been a close contact to a confirmed case and is in quarantine, that if symptoms develop, we would ask them to obtain a test and isolate pending the results of that test. So that is the return to school algorithm. And I'm going to kind of truck on here, but hopefully we'll have some time if there are questions about that. I just want to briefly show you, this is the protocol for schools assisting public health with close contact identification for COVID-19 cases. So just in case questions come up for your patients or their families, the way that things work in terms of schools is that if there has been a case identified in a school or contacts of a case are affiliated with a school, our case investigator, when public health investigation is completed, ask that family to notify the school of their positive test result and or household contacts who have been quarantined. If that individual who is a case has been on campus during their infectious period, then our primary points of contact in each school system will contact our health department liaison, that's me, and we will talk through contact tracing, gather all the information that's needed to be sure that contact tracing is completed appropriately and completely, and then we will recommend quarantine of close contacts accordingly. And we do ask schools to work with us to help facilitate notification of those close contacts because the schools already have contact information and have an existing relationship with those students and family members. So the health department is the one who is partnering with the school to make those determinations around close contacts and who needs to quarantine. And then the schools are acting on behalf of the health department to notify those families and students and staff. So if you get questions about that, that's how that works. We then submit those folks to our centralized contact monitoring team in our central office in Nashville, and folks receive calls through their isolation or quarantine period and may request a letter of release following completion of their isolation or quarantine period. This is the case response rubric that, and I know you can't see that, I know everything's really small there. This is also available on the TDH website's coronavirus information page under educational resources. But just to give you an idea, the case response rubric is divided up into those White House task force zones. So there's white and yellow and red. Like I said, orange was just added, so the case response rubric has not yet been updated to reflect an orange zone. But the zones are are based on levels of the new case rates and test positivity. And so it just gives schools some guidance about what they need to do in terms of each identified case, 2 or more unrelated cases or 2 or more linked cases within a 14-day period, and then guidance based on, were they in the same building, were they in the same classroom, do they have some sort of an epilink, and then can contact tracing confidently be performed? Can we confidently say that we're going to be able to identify all close contacts and perform contact tracing with those folks? If so, or if not, it gives guidance about classroom closures, wing closures, building closures, program closures, district closures. And so we ask our points of contact in each school or school system to contact us and work through exactly what it looks like for that school or school district, with the intent to keep folks as safely as possible in their schools if possible. So limiting the number of closures that are necessary to protect the public's health. Okay, so just a kind of a brief kind of summation of that. So mitigation strategies, as we briefly touched on, are really primarily intended to limit the spread of and exposure to respiratory droplets. So we use cloth face coverings to keep our own respiratory droplets to ourselves. We use physical distancing to make sure that those escaped respiratory droplets don't land on anybody else. We use hand hygiene to make sure that we don't have virus on our hands and then touch our own face and risk viral transmission that way, etc. I will just take the opportunity to mention that cloth face coverings and physical distancing are considered complementary strategies. So it's not one or the other, it's both. So cloth face coverings are source control, keeping those respiratory droplets to yourself. Physical distancing is environmental control, trying to keep the respiratory droplets away from one another. Case investigation and contact tracing obviously is intended to identify folks who have the virus and individuals who've been exposed to the virus, and then isolation and quarantine are intended to separate individuals who are or could become infectious from the rest of the population to interrupt disease transmission and decrease spread. So that's why all of those things are a part of the public health response and the mitigation of transmission of SARS-CoV-2, especially as it applies to schools. Okay, whew, I've left a little time, I think, maybe, I don't know, a couple minutes in case there are questions. I've got my contact information on here. You are more than welcome to contact me by email at any time. I check my email pretty much constantly, and I'll get back to you as promptly as possible. If you have questions, if you have concerns, if you have feedback or recommendations, or if you want to find data or other resources or documents, I'm happy to point you in the right direction. And now I will hush and take your questions.
Hello, Dr. Thomas. I'm Varun Kumar. I'm one of the pediatric hospitalists. Thank you for that a very nice update. I know, this has been on our minds for several months, the COVID pandemic. I have actually a couple of questions related to the household contact quarantine system. First, is this honor system? It's an honor system, correct? You're requesting that they do this, and there's no kind of enforcement.
Great question. And generally speaking, yes. So there's no direct active policing of individuals in quarantine. So once someone is advised to quarantine, you're correct. We are depending on that individual to act in accordance with those recommendations. However, if it comes to our attention that someone is actively in defiance of quarantine recommendations and it is a threat to the public's health, that can be enforced with a public health directive.
Okay. That leads to my second question. As we know, the COVID pandemic has impacted the impoverished, lower socioeconomic groups, both medically and economically, more than other groups. With the household quarantine policy, I'm worried, I'm concerned. I don't know if this has been discussed about the impact on those who are poorer or lower socioeconomic. They're less likely to have a large house with multiple bathrooms to isolate the household contacts, so more likely to need the 24 days versus the, I forget what the smaller days is. They're more likely to need to be physically at work as opposed to doing remote work. And they're much more economically vulnerable to missing 24 days of income. Are there protections by the state for them to keep their jobs and have this as paid leave, or is it up to each individual employer?
It's a great question, and I'm not sure I can completely address it comprehensively, but I'll take a stab at some of it. Certainly, we understand, appreciate, and share your concerns about the disparate impacts on a variety of folks in different socioeconomic conditions. And we've definitely seen that there have been negative consequences for folks who have had to quarantine for extended periods of time in terms of lost wages and so forth. I cannot speak directly to the protections that are in place. I would be paraphrasing at best, and so I should probably leave that to someone else to address. I do know that there is certain payroll protection and leave protection, but I don't know the parameters of that, and I don't know to what degree that is actually dependent on individual employers. I can certainly try to get you a link to folks who could answer that more comprehensively. And I can say that as our local and regional health department, we try to work very closely with populations who are negatively impacted by any disease process, and link them to resources in the community to meet their needs to the best of our ability. And we're always available to do that if you become aware of specific situations where there are community resources we could link them to. But in terms of wage protection in particular, I'll have to get you to someone else who can answer that better than I can.
No, I appreciate that. Thank you very much. And I would appreciate the link. I have a last comment to make on that note, that if there was not to be wage protection or even job protection, like they might get fired, if I was poor and knowing what I know about public health, but I was poor and I was told household quarantine, and the decisions between putting food on the table of my children and paying medical bills or quarantining, I know what I would do. And so you can argue that wage protection is actually a public health measure because it's going to strengthen the quarantine system, is what my argument would be, not in addition to helping these families who need that. I think the quarantine system would be strengthened by such a protection because I think more people will be less likely to do it if they're not sure they'll keep their job.
Certainly, and I appreciate your feedback and lived experience there, and we certainly don't disagree with anything that you've mentioned. That wage protection is certainly a part of the overall public health response, and would strengthen the ability for folks to comply with quarantine. I would say that we do have additional concerns about folks not seeking testing due to concerns about the need to isolate and family members quarantine. if they should become positive. So we are concerned about the far-reaching public health implications of folks not only not being able to comply with quarantine, but also not initially seeking testing or otherwise seeking care because of those concerns. So please know that those concerns are heard and taken to heart.
Thank you very much.
Well, Dr. Thomas, we really appreciate you coming out and giving this talk. I thought it was excellent. We do need to, I think, wrap things up so folks can get back to clinical duties, but really appreciate you coming out and also, sending out your email address. I'm sure folks have lots of questions about this issue because there's so much up in the air. So thank you.
Really appreciate you, Dr. Thomas. Thank you.
Absolutely. It's my great pleasure. Thank you all for having me today. And don't hesitate to use my email address. I wouldn't give it to you if I didn't intend to answer questions. So please shoot me your questions, and to the best of my ability, I'll either answer them and address them or get them to someone who can. Thank you all so much for your time today.
Thank you.
Thank you. Thank you.